Hello, my name is Hannah Gay, and I'm a senior in JWS. I concentrate in healthcare management in Wharton, and my senior thesis is about medically assisted treatment for opioid use disorder in opioid addiction treatment centers. So that kind of sounds like a lot, so let me back up and explain all of those parts. So, as I'm sure you've heard about, a lot of people in America right now are really panicked about the opioid addiction crisis. You've heard about it a lot in the news and everything because last year alone, about 60,000 people died from opioid overdoses. And this problem has been going along for a long time, though, and we've known that prescription opioids are addictive since the early 2000s, but the death and overdose rate has increased drastically in the last 5 to 10 years alone. This is kind of due to a lot of factors, but among those factors is that people have become more addicted than they were, or more people have become addicted than were before, and also new opioids are a lot more dangerous than they used to be. So when I say opioids, here's what I mean. So there are a few different drug types. There are the prescription drugs that you've heard about, like oxycodone, which is branded as OxyContin, hydrocodone, which is branded as Vicodin, morphine, codeine, list goes on and on. Really opioid painkillers, and they're prescribed as painkillers. When people become addicted, they typically start on pain medications like these ones for like a surgery or anything that's causing them pain. And they start through like normal distribution channels like pharmacies and doctors and all. In addition to that, there's also heroin, which has been manufactured by poppy seeds from poppy seeds since at least the 1800s and probably as long as humans have been growing poppy seeds. And it's always been illegal in the US, and it is now. And then there's also, very recently, there's a drug called fentanyl, which was originally a legal drug. It was used in a medical sense. It's an extraordinarily powerful painkiller, but more recently it's really hit the black market. It's a synthetic opioid, unlike heroin, and it's usually made in China. It's legal in the US, like I said, but it's more often sold through illegal channels because of all the opioids. It's the easiest to smuggle and the cheapest to make. So like a kilogram of fentanyl, which is like about this much, not like you can easily hold it in two hands. I could put it in my backpack. That's enough for anywhere between 50 million and a billion doses. Like normal medical doses, half those numbers if you want like a very strong high, but nonetheless, 25 million doses in a single kilogram like that, and that only costs about $6,000 to make. So it's pretty easy to make and smuggle into the US, and then it's sold on the black market. Just like a few specks of fentanyl is enough to kill someone like me. People who have been using opioids a little bit more, but like policemen who are doing drug busts and stuff, one of them brushed it off, like got a little on his shoulder, brushed it off with his hand, and went into an overdose just from it seeping through his skin into his bloodstream. It also gets mixed into heroin and cocaine a lot, so people don't even know that it's in the drugs that they're taking. So they take the drugs, don't know the fentanyl is in there, and they die, or at least overdose. So then, now the story is about 2 to 3 million people in the US are addicted to opioids, and most of them are not receiving any treatment, but many of them are, and there are a lot of different types of treatment for opioid addiction. The old-fashioned way is kind of like behavioral counseling. The 12-step process is probably something that you've heard about that can be used with any type of addiction, but there's also like residential detox and counseling and other stuff like that. There's also another method which is called medically assisted treatment, and this is like a little bit newer. This uses a specific class of drugs, which are called opioid agonists or antagonists, and they block the receptors in the brain that receive opioid drugs, and so they keep someone from getting high, and they also keep people from really craving the drugs that they want. And drugs that are in the class of opioid agonists are methadone, buprenorphine, and naltrexone are the most common ones. You may have also heard of naloxone. That's different. That is the drug that you administer to someone who is actively overdosing. It too is an opioid agonist, but it's used in a different sense. So only treatment centers that are federally recognized opioid treatment centers can dispense methadone, and only doctors who have gone through a specific type of training can dispense buprenorphine. But in general, it's a little bit easier for a doctor to be certified to do buprenorphine than for a center to be certified to do methadone. But there's a big limit on the supply of medically assisted treatment through these registration programs, and doctors and treatment centers can only have a certain number of patients each that they're treating with methadone or buprenorphine. It used to be 75 per doctor. I think it's a little more now because states are realizing that this should be more expanded. So another thing that limits people's ability to get medically assisted treatment is their ability to pay for it. Insurance sometimes does cover it, and Medicaid does cover the treatment as well. For those who don't know that much, Medicaid is a national program. A lot of it's federally funded, but it's administered by the state. So each state gets to choose who they want to cover and what they want to cover, basically. And the states are pretty much liable for about half the budget of their own Medicaid programs. So before the ACA, each state kind of chose who they wanted to cover. A good example, it really only covered like the needy poor. So in some states it would cover everyone under 100% of the poverty line, but in other states it would only cover like children who are under the poverty line and pregnant women and like maybe young mothers, maybe fathers, if poor fathers if they're lucky. But state Medicaid programs almost never covered childless adults at all, and it didn't cover other adults well. But when the ACA passed, it gave the every state the option to expand Medicaid, federally funded. 90% of the funding would come from the federal government, and then it would cover everyone under 138% of the poverty level. So in 2014, 19 states expanded Medicaid, so then we have all the states that expanded. So everyone now in those states is covered who's below 138% of the federal poverty line, and then the other 31 states, nothing changed at all. So now we have a bunch more people in these states who now have health insurance that they didn't before. So this is where my thesis actually comes in. So what I want to know is, how did opioid addiction treatment centers change their behavior in these states, in the states that expanded Medicaid? So really what I want to know is, did more of these treatment centers in the expansion states expand their ability to provide medically assisted treatment than in the states that did not expand? So preliminary results are pretty interesting so far. Overall, the rate of patients receiving medically assisted treatment has increased since 2011, which is great. That's the baseline data I'm using. So in 2011, only 25% of people receiving treatment for opioid addiction were receiving medically assisted treatment. But in 2017, that was up to 31%. So that's good. We think this is positive because medically assisted treatment's a lot more effective than conventional methods at keeping people from continuing their addiction. We also know that this number is different in states that expanded Medicaid versus those that didn't. So generally the trend in all states is more people are getting, a higher percent of people in treatment are getting medically assisted treatment. But we also know that it looks different. So in states that did expand Medicaid, you get percent of people who are receiving treatment, you hit 2014, and that slope increases. So now, whereas in states that didn't expand Medicaid, it's kind of a constant rate. So we know that more people in states that expanded Medicaid are getting medically assisted treatment than in states that did not expand Medicaid, and that is a significant difference. So that's a really cool finding so far, but what we really want to know is whether this was due to the treatment centers existing providing more medically assisted treatment to patients, or whether more treatment centers expanded their ability to offer medically assisted treatment. So basically, we know that people are getting more medically assisted treatment. We want to know if the supply itself actually changed. So that's where the rest of my thesis will come in. And for the final results, catch my published thesis. Thank you. I hope you enjoyed watching, and have a great day.